Welcome to the deep dive. Today we're getting into something really important in managing heart rhythm problems, antiarrhythmic drugs.
That's right.
And if you're tuning in via KMR Advise, our goal is always clarity on complex stuff. This is basically set up like one of our lecture discussions on the KMR Advise YouTube channel. So if this helped you out, please do share it, subscribe for more deep medical content, and definitely hit that bell icon. You don't want to miss what's coming up.
Absolutely. And our mission here is really to pull out the key information on these antiarrhythmics from the overview document we're using. And present it clearly, engagingly, just like we aim for on KMR Advise.
Exactly. And yeah, our source is a pretty solid overview doc on these drugs. So what's the plan? How are we tackling this?
Well, we're going to go through it sequentially, just like the source material lays it out. No jumping around. We'll start with the uses, then the classification, that von Williams system. Then how they work, the mechanism, how the body handles them, pharmacokinetics. Then the downsides, adverse effects when not to use them, contraindications, drug interactions, and then wrap up with some, key clinical takeaways.
Perfect. Nice and logical. All right, let's dive right in then. Uses. Where do these drugs actually come into play? Seems like quite a few scenarios.
Oh, definitely. You can think about it in terms of how urgent things are. First off, there's acute arrhythmias. These are the sudden, really problematic ones. Think supraventricular tachycardia, VT, AFib.
Right, the emergencies.
Exactly. The goal there is usually stop it now, or at least get the rate under control fast.
Okay, so that's putting out the fire. What about stopping it from flaring up again?
Yeah, that's the chronic prevention side. Using antiarrhythmics long-term to make it less likely for things like AFib, atrial flutter, or VT to come back. Trying to keep things stable.
And I know sometimes, like with AFib, just controlling the speed of the heart is the main thing.
Absolutely. Sometimes getting back to a normal rhythm isn't the main goal, or maybe it's just not possible. So in AFib or flutter, we might use drugs like beta blockers, digoxin, or verapamil just to keep the heart rate from going way too fast. That's rate control.
Gotcha. Acute chronic prevention, rate control.
Yeah.
Anything else? Any sort of special cases?
Yeah, a few important ones. Like after a heart attack post-MI, patients are at higher risk then. Beta blockers and amiodarone are pretty key in that situation. And then there's torsastepoint, that specific kind of twisting pattern VT. The go-to there is often magnesium sulfate, maybe pacing too.
Interesting. Different approaches even within arrhythmias. What about using them around procedures?
Yep. Good example is adenosine. We give that as a fast IV push-a-bolus to try and stop acute PSVT right in its tracks.
Ah, the adenosine slam.
That's the one. And sometimes drugs like amiodarone or procainamide are used alongside electrical cardioversion, the shock, to help it work better.
Okay, that makes sense.
Yeah.
So a good picture of when we use them. Let's talk classification. The von Williams system sounds foundational.
Oh, it absolutely is. It's sort of the standard way we group these drugs. It's based mainly on how they affect the heart's electrical activity, specifically the action potential, 4 main classes.
Right. Let's start with class I, sodium channel blockers. What's the deal there?
So class I drugs, they block the fast sodium channels in the heart cells. This mainly slows down that initial rapid electrical spike phase 0 and slows how fast the impulse travels. But it's split into 3 subclasses: IA, IB, and IC.
Okay.
Class IA, think quinidine, procainamide. They block sodium channels, and they make the action potential last longer. So they prolong the APD and the QT interval you see on the ECG.
Okay, so slows conduction and lengthens repolarization. What about IB?
Class IB, like lidocaine or mexiletine, they also hit sodium channels, but they actually shorten the action potential duration. Interesting difference, right?
Yeah.
And they tend to work better in tissue that's ischemic, not getting enough blood, or firing really fast.
Huh. Okay, contrast noted. And IC.
Class IC flecainide, propafenone, these are really potent sodium channel blockers, big effect on slowing conduction velocity. But unlike IA, they don't really change the action potential duration much.
Got it. So class 1, sodium channels, but with those key differences in APD effects. Next up, class 2, beta blockers.
Yep, class 2 is your beta blockers. Propranolol, esmolol, sotalol too. Their main job is blocking those beta-adrenergic receptors. This lowers CAMP inside the cell, slows the heart rate, slows conduction, especially through the AV node.
The gateway node.
Exactly. Now, sotalol is a bit of an oddball because it also has class 3 activity. It blocks potassium channels too.
Ah, double duty. Interesting. Okay, so class 3 must be the potassium channel blockers then.
You got it. Class 3, amiodarone, drondarone, ibutylide, difidylide, and as we just said, sotalol. They work primarily by blocking potassium channels. This action delays repolarization, makes the action potential last longer, and again, increases the QT interval on the ECG.
Okay. And finally, class 4.
Class 4 are the non-dihydropyridine calcium channel blockers, specifically verapamil and diltiazem. They block L-type calcium channels, mainly affecting the SA node, the pacemaker, and the AV node. So they're good for SVTs and rate control in AFib.
Right, slowing things down at the top. So those are the big 4 classes, but I see others mentioned too.
Yeah, just a few important ones that don't quite fit the main classes, like adenosine, we mentioned that for PSVT, digoxin for rate control and AFib flutter, and then things like atropine and isoprenaline, which have more specific uses.
Okay, great framework. Now the overview jumps into keynotes. First one, proarrhythmia. Sounds counterintuitive.
It is, and it's super important. Proarrhythmia means that these drugs, meant to stop arrhythmias, can sometimes paradoxically cause new ones or make existing ones worse. It's a serious risk.
Wow.
We really learned this the hard way from big trials like CAST and SWORD. They actually showed increased mortality, increased risk of sudden death with certain antiarrhythmics in some post-heart attack patients. It really highlights the double-edged sword nature of these drugs.
Okay, that is critical. The very treatment can be harmful. The second keynote is about mortality benefit after a heart attack, post-MI.
Yes, another crucial point. The evidence we have strongly suggests that only beta blockers and amiodarone have been consistently shown to actually reduce mortality, reduce the risk of sudden death after someone's had an MI.
So not all antiarrhythmics help you live longer in that situation.
Exactly. It really underscores why beta blockers are standard post-MI care and why amiodarone is sometimes used there, despite its side effects.
Okay, really vital distinction. Let's get into the nuts and bolts now, mechanism of action. How do they actually work?
Right. So stepping back a bit, it starts with that ion channel blockade we just classified. Class 1, block sodium, slow phase 0 depolarization, slow conduction. Class 2, block beta receptors, lower CAMP, slow nodal conduction. Class 3, block potassium channels, prolong repolarization, lengthen the action potential. Class 4, block calcium channels, slow SA and AV node conduction. That's the basic electrophysiology.
Okay, that's the cellular stuff. What effects are we actually aiming for clinically?
Well, clinically, we're trying to suppress those rogue electrical signals, ectopic foci. We're trying to break up those short circuits, the reentry loops, and we're trying to calm down cells that are firing off impulses when they should an abnormal automaticity.
Right.
The ultimate goal is either get back to a normal sinus rhythm and stay there, or, if that's not the plan, just control the ventricular rate, keep the bottom chambers from beating too fast, like in AFib.
And then once they've done their job, how does the body get rid of them? The termination part.
Right. So metabolism breaking them down mostly happens in the liver for most of these drugs. Often involves those CYT enzymes.
Okay.
Lidocaine and digoxin are a bit different, significant kidney metabolism there. Then excretion, getting them out of the body, is mainly via the urine.
And that matters for kidney function, I guess.
Hugely important. If someone's kidneys aren't working well, they might not clear the drug properly. It builds up. Risk of side effects goes way up. So you often have to adjust the dose in renal impairment. Really got to watch that.
Makes total sense. Okay, pharmacokinetics next. How the body handles the drug over time. The overview has a table, which is handy for our KMR advised viewers.
Yeah, PK is crucial for safe use. Tells you about absorption, distribution, metabolism, excretion. So the table gives examples like lidocaine IV, super fast onset, metabolized by the liver, excreted by the kidneys.
Okay.
Contrast that with amiodarone, oral or IV, much slower onset. It hangs around for ages, gets metabolized extensively in the liver. That CYP3A4 enzyme is key, and it's mainly eliminated in bile, not urine.
Big difference. Slow onset, long duration, bile excretion for amio. What about propranolol and verapamil?
Propranolol and verapamil, whether oral or IV, usually start working within, say, 1 to 2 hours. Both heavily metabolized by the liver, excreted in the urine. Pretty standard PK for many drugs.
And adenosine, the super fast one for PSVT.
Ah, yeah. Adenosine's unique. Rapid 5-push, onset is almost instant, like seconds.
Wow.
And it's broken down incredibly fast right there in the blood by enzymes and red cells and blood vessel walls. So fast, it doesn't really have a typical excretion route. Effects are gone in, less than a minute usually.
That rapid breakdown explains why it's just a quick hit for SVT. Okay, let's move to clinical pearls. Always good for practical tips on KMR advice.
Definitely. First pearl. Amidarone's crazy long half-life. We're talking weeks. Yeah. Which means it takes ages to build up to a steady level, and ages for its effects and side effects to go away after you stop it. Plus, think about drug interactions. They can linger too.
Wow, okay. Need to remember that. Second pearl.
Lidocaine. It's basically only used IV for arrhythmias. Why? Because if you take it orally, the liver chews up almost all of it before it even gets into your main circulation. That's the high first-pass effect. Makes oral pills useless for the heart rhythm issues.
Got it. 4V only for lidoarrhythmias. Good pearls. All right, next up. Potential downsides. Adverse effects. I imagine these potent drugs have quite a few.
They certainly can, and maybe the most worrying one is that proarrhythmia we talked about.
Right, causing arrhythmias.
Especially with Class IA and Class 3 drugs, you worry about torsades de pointe, that dangerous VT with the twisting look on the ECG. If that happens, you stop the drug immediately, give IV magnesium, maybe pacing.
Okay. What other kinds of side effects?
Well, you can get CNS effects, especially with lidocaine tremors, confusion, even seizures if the level gets too high. Dose adjustment is key there. Cardiac effects, too. Beta blockers, verapamil, they can slow the heart rate too much, cause bradycardia, or block the signal between the atria and vesicles. AV block. Might need atropine or pacing if that happens.
And amiodarone seemed to have its own list.
Oh, yeah. Amiodarone is notorious. Pulmonary toxicity, like fibrosis, scarring in the lungs, that's serious. Usually means stopping the drug, maybe steroids. But it can also mess with your thyroid, your liver, your skin. Needs lots of monitoring.
Wow. So careful monitoring sounds non-negotiable with these. Okay, when should we definitely not use them? Contraindications.
Right. There are some absolute no-goes, like significant heart block if the patient doesn't have a pacemaker, severe bradycardia already, sick sinus syndrome, again, without a pacemaker backup. You just don't risk making things worse.
Makes sense. And relative contraindications,
Well,
where you proceed with caution.
yeah, relative ones are where you weigh risk versus benefit very carefully, like low blood pressure, hypotension, especially if considering verapamil or beta blockers that can lower it further.
Okay.
Asthma is a relative one for beta blockers, particularly the non-selective ones. And significant structural heart disease can make Class IC drugs riskier because of proarrhythmia potential. If you do use them in these situations, you watch the patient like a hawk.
Right. Weigh the risks. Monitor closely. Okay, next hurdle. Drug interactions. I bet these are common, something our KMR Advise audience really needs to know.
Extremely important. Amiodarone, again, it messes with those liver enzymes, the CYPs. So it can boost the levels of other drugs like warfarin, digoxin, phenytoin, potentially causing toxicity.
Okay, big one.
Quinidine can block that P-glycoprotein transporter, PGP, which also bumps up digoxin levels. Risk of dig toxicity there. Combining beta blockers with verapamil or diltiazem, they work together to slow the heart rate and AV conduction, so you can get severe bradycardia or AV block. Be very careful there.
Synergistic effect.
Exactly. And a huge one. Combining multiple drugs that prolong the QT interval. Each one adds a bit of risk, put them together, and your risk of torsades de pointe really climbs. So you absolutely have to check the patient's full medication list before starting any antiarrhythmic. Thorough MedRec is vital.
Absolutely critical. Okay, the overview gives an exam tip next, reinforcing something we've heard.
Yeah, it just hammers home that point about amiodarone.
Yeah.
Lots of arrhythmias, very broad spectrum.
Yeah.
But comes with that baggage of many side effects and interactions. It's a trade-off you always have to consider.
Got it. Then we get some specific dosage and clinical pearls for common drugs. Practical stuff.
Yeah, like for acute PSVT adenosine. Typically 6 milligrams rapid IV push. If no luck, try 12 milligrams. Lidocaine for VT. Usually 1 to 1.5 milligrams per kilogram IV bolus, then start an infusion. Amiodarone for VTVF, maybe 150, 300 milligram IV over 10 minutes as a load, then an infusion.
Right.
Verapamil for SVT. 5 to 10 milligram IV, but give it slowly to avoid dropping the blood pressure too fast. And propranolol for AFib rate control or VT, maybe 1 milligram IV. Repeat carefully as needed.
Good specifics. And there's a pediatric note, too.
Simple but important. Pediatric doses are almost always weight-based, and generally you avoid Class IC drugs in kids because of higher proarrhythmia risk seen in that group.
Good to know. Next, toxicity and management. What if things go wrong?
Okay, torsades de pointe. We see that polymorphic VT, the long QT management, 4 of magnesium sulfate, maybe pacing, amiodarone toxicity. Think lungs, liver, thyroid problems. Main thing is stop the drug, supportive care, maybe steroids for inflammation. Lidocaine toxicity. Usually CNS stuff, confusion, tremors, seizures. Stop the infusion, give benzos like diazepam or lorazepam if they're seizing.
Okay, clear plans. We're near the end. Black box warnings and keynotes. These sound serious.
They are. Top of the list, those cast and sword trial results led to black box warnings for Class I drugs, especially IC, and post-MI patients with less severe arrhythmias because they increase mortality. Don't use them just to clean up the ECG after a heart attack.
Critical warning.
Amiodarones, black box warnings, pulmonary fibrosis, hepatotoxicity, thyroid issues, huge potential risks, beta blockers, warning about stopping them abruptly, can cause rebound tachycardia, worsen angina, even sudden death if the patient has coronary disease. Taper them off.
Right.
And that high-yield fact gets repeated. Only beta blockers and amiodarone have shown a clear mortality benefit, reducing sudden death risk after an MI.
Okay, serious warnings noted. Lastly, an antiarrhythmic drugs final exam checklist. Good recap for KMR Advised listeners.
Yeah, quick summary. Mechanism. Know the ion channels, Na+, K+, A, 2+, and beta blockade, key drugs. Lidocaine for acute VT. Amiodarone broad spectrum. Adenosine for PSVT, contraindications. Heart block. Bradycardia, asthma for beta blockers. Toxicity, Torsades with IAI3, amiodarone organ issues, clinical pearls, cast sword, amio interactions, avoid suppressing benign arrhythmias long term.
Fantastic summary. So that wraps up our deep dive today. We've gone through the uses, the Vaughan Williams classes, how they work, how the body handles them, the risks, interactions, key points, everything laid out in the source. And as we've seen, these are incredibly useful drugs, but man, they carry risks. Understanding them inside and out is just essential for using them safely and effectively. Hopefully for everyone following on KMR Advised, this has shed some light.
It really underscores the complexity, doesn't it? And thinking about that pro-arrhythmic potential, it really makes you pause. For anyone listening, especially students or trainees, maybe final thought, how does knowing these drugs can cause arrhythmias change how you think about choosing one and how closely you monitor the patient? It's a really fundamental question in practice.
Absolutely. Great point to ponder. And hey, for more deep dives into medical topics like this one, please do check out the KMR Advised YouTube channel. We're always adding more content to help build that solid understanding.
Definitely worth a look.
If you found this session useful, please give it a like, share it with anyone else who might benefit, and if you haven't yet, subscribe to KMR Advice. Oh, and hit that notification bell so you catch our next deep dive. Thanks so much for joining us today.